let's move on and let's talk about myelofibrosis. So Jamile, let me turn to you as our resident pathologist and talk about not only the signs or symptoms of myelofibrosis, but how do we make this diagnosis?
Yes. So I think like other MPNs, the MF can actually be asymptomatic, but obviously to a much lesser extent. About 25% of patients with MF may be totally asymptomatic. On the other hand, patients with MF are more likely to have splenomegaly, so that would be probably one cornerstone of their symptomatology. They will have spleen-related symptom. Most will end up either present with anemia or end up developing anemia. And then some might complain of bone pain, night sweats, weight loss, early satiety. But I think it's so important, like when we talk about symptoms and signs, I think a lot of it depends on how hard are you digging when you're talking to a patient, you know? So often they may not tell you that they have bone pain. Why should my hematologist know about my arthritis, presumably? But that's why I think assessing symptomatology at the time of diagnosis is extremely important. So how is myelofibrosis diagnosed? Well, truly, the only way that you can confirm the diagnosis or make it, for that matter, is by performing a bone marrow biopsy. I mean, we can all have our clinical suspicion that perhaps this patient may have MF, but the proof is in the pudding and by doing a bone marrow biopsy. And obviously the WHO 2016 criteria outlined what is prerequisite for making that diagnosis, and that is clustered atypical megakaryocytes with 2 to 3 plus reticulin fibrosis, demonstration of clonal hematopoiesis with JAK2, MPL, and CALR mutation, and ruling out many other entities, for example, MDS with fibrosis or CML with fibrosis, that you can safely say that this isn't an alternate myeloid neoplasm. And of course, you have to demonstrate other minor criteria, and I think there's like 4 or 5 of them, such as leukoerythroblastic picture in the peripheral smear, having high LDH, or anemia or leukocytosis, and as we talked about, splenomegaly and constitutional symptoms.
The one factor here is that I see this all the time for some reason. Wherever there is in a patient sample a fibrosis, they always say, oh, it must be myelofibrosis. Fibrosis does not mean myelofibrosis as a disease entity. And we have MDS with fibrosis that we see quite often in the consultation. This is what we end up with when the patient is referred with myelofibrosis. There is some confusion about that particular fact, but it's pretty simple. Fibrosis does not equal myelofibrosis as a disease. It needs to be worked up.
Yeah, the pathologic hallmark, as Jamile said, is this megakaryocytic morphology, the hyperplasia, the clustering, the atypia, all of that is more important. In fact, in the pre-fibrotic myelofibrosis, that's what's left, actually, is just the megakaryocytic changes. So as opposed to PV, where we looked at risk factors or risk stratification based on risk of thrombotic events, there have been a number of risk stratifications in myelofibrosis that are related to mortality, overall survival, which have evolved over the years. I think the first one that I used were the International Prognostic Scoring System, the Cervantes criteria. Some of you are probably involved in that analysis of thousands of patients with about 1,000 patients with myelofibrosis, and 5 factors came out to be very important in determining prognosis: age over 65, constitutional symptoms, hemoglobin under 10, white count over 25,000, and circulating blasts above 1%. What's not on the list? Splenomegaly is not on the list, which is interesting. But if you have none of those risk factors, you have low-risk disease. That was only about 10% of the patients. Most of the patients have intermediate or high risk. In high risk, it's 3 or more of those, and the median survival is 2 years. Intermediate 2, you have 2 risk factors, and that's a median survival of about 4 years, and it's about 8-year median survival, 6 to 8 years for intermediate 1. Now, there have been some modifications of that over the time. The Cervantes criteria look at criteria diagnosis. There was the dynamic international prognostic scoring system, which basically came up with the same 5 criteria, but double weighted the anemia as being very important. And then finally, the most recent iteration that I know of is the revised dynamic international prognostic score, which added thrombocytopenia, added cytogenetic changes, added transfusion dependence. But I think the important point here is that the majority of the patients that we see in clinic are patients with intermediate to high-risk disease, and those patients have quite a limited life expectancy and need to be, managed appropriately.
So, as I share with my trainees, one, there's more prognostic scores that we could keep track of. And two, I think they're important in terms of what they inform us about the disease. There's even one more iteration on this theme of these prognostic scores involving some of the new molecular mutations. So,
that was going to be my question to you.
Yeah, so presented at ASH, Professor Vanucchi, who he and his group, along with collaborators, have been very active. And again, they found that some marriage of some of these clinical features and some of the new molecular features have been very helpful. They did analysis in let's say, transplant age patients under age of 70 that they call the MIPSS 70. Now, what I share with trainees is that they are confronted with prognostic scores from colon cancer all the way through MF. So don't memorize any of them, but know where to find them when you need to. And then, be mindful of the lessons that they tell us, but also know that they have limitations. So one of the limitations with these, again, why is splenomegaly not in there? In large part because most of the retrospective data doesn't really have good quality data regarding the size of the spleen to be able to make good conclusions. I had a patient that had ascites, and in the ascites, it was filled with circulating megakaryocytes in the ascites. That clearly was a huge red flag for me. That's not on any of the prognostic scores. So it's always important to have an important part of common sense. But without question, it certainly has advanced the discussion in heterogeneous disease, along with a good amount of clinical common sense. Which are the patients you're really worried about really progressing along that myelofibrosis phenotype, worsening debilitation, big spleen, death from a consequence of that, or really they're heading toward AML. Two different phenotypes, different implications in terms of therapy.
Yeah. And you see, the other thing is that why are we prognosticating? We are prognosticating to select patients.
I think it's to publish papers.
Okay, that's one reason.
That's
maybe.
one. Okay, that's fine.
But why practically, right? Practice. You're prognosticating to select patients that you would refer to a transplant. Then the patient is seen by the transplanter, the doctor who does the transplant, and he would look at other factors in addition to your prognostic scoring system. Comorbidities. If you have a heart problem, you have a pulmonary hypertension, you have some other kidney problem, you may be qualified to go for a transplant based on our IPSS or revised IPSS or MySEC or many others. You are not going to make it to the transplant because you have comorbidities. So there are other factors that needs to be accounted for in that transplant setting other than what we are trying to do in our own practice. And we are improving. Let's say that, yes, there are so many of them. We have a lot of papers, a lot of even online systems to calculate that risk. And none of them is perfect, and it has to be individualized at the end.
Right. Yeah, I'd like to add to that clinical point. I think I always bring that, even in MDS, like some of those models will incorporate things, for example, like age. So I always say, like in a decision there is prognostic information from the models that you could tell the patient the expected survival for 100 patient is X. But then also we are using them as, the therapeutic tools to decide who we are taking to transplant. So if I make somebody a higher risk just by the fact they are above age of 65, I give them a point that takes them from intermediate 1 to intermediate 2, I'm not sure that I'm going to send that patient to transplant. I look at disease-related risk factors to decide on transplant, for example. But from prognostic value, there is no doubt that somebody who's older, will have worse outcome, unfortunately, than younger patients from that stand. The other thing now that adds to the complexity is those somatic mutations. So we know that certain mutations that I think several groups had reported on that have independent prognostic value, like presence of XL1 or SRSF2 in myelofibrosis, the triple, what we call triple negative now, absence of the phenotypic driver mutations. I think some of the mutations may predict higher chance of progression to AML. But then yet we don't know, or I think we are starting to learn about what's the impact of something like transplant on those mutations. Are we gonna do a patient favor because if they have SXL1 mutation, we send them to transplant, that the transplant overcome that or not? I think we are starting to get that information, but we are not yet there. So sometimes I struggle with that. Okay, I upstaged the patient. Now what do I do with that? So.
Right.